Hello, and welcome to a session of digital slide review and sign out. I'm Dr. Louis Hassel. Our program, product of the collaboration between the Digital Pathology Association and past presenter known as the Digital Anatomic Pathology Academy. If you tried to watch this video earlier, you'll note that I had not paid my audio engineer quite enough to record the sound the first time through, so we'll hope that this time we don't have that technical problem. Our cases today come from the realm of GI pathology, and we're going to talk specifically about a young 12-year-old patient who's experiencing difficulty swallowing and has had recently a change in their dietary use of supplements due to some changes in their athletic program. So on endoscopy, the gastroenterologist noted this peculiar appearance of the esophagus. Note these concentric rings, or what is sometimes called trachealization of the esophagus. This is characteristic of this particular disorder. Other features that can be seen in this particular entity is some furrowing, which you see a little bit of here, as some of these sort of plowed field type of lines vertically in the esophagus also begin to appear. And some patients have, or some people have referred to this also as felinization, this combination of traits here. Some patients who have this disorder also will have strictures or rings that develop. The endoscopist took a couple of biopsies from the mid portion of the esophagus. Ideally in this disorder we get biopsies from several levels, but they provided this appearance here, and as we can see, this is rather a bluish biopsy that's not quite as pink as usual normal squamous epithelium in the esophagus would appear. And we can also see that there is some white spaces in between the cells, so there's some evidence here that we've got interstitial edema that's highlighting each of these individual keratinocytes of the esophagus. Then as we come into higher magnification, we see that as well as that white space, there's also a lot of interstitial pink cells here. And as we look at higher magnification, we can appreciate that some of these have sort of a bilobed nature of the nucleus, and these are eosinophils. As well, we might see there are a few lymphocytes present here. This certainly appears to be a very active esophagitis with lots of eosinophils, lots of edema, and perhaps some degree of compensatory hyperplasia going on here as we don't have much normal surface epithelium. Here's another example, this one oriented with gel foam. And as we look here, we notice that this is a little bit less pronounced. We have more lymphocytes along with the eosinophils here. We still have some edema and a lot of these superficial eosinophils and eosinophil granules between the cells, but not quite to the extent we had in that earlier biopsy. So in looking at these, we're thinking that there's some sort of a cause for a dense eosinophilic infiltrate, active esophagitis. Of course, the reaction patterns that we can see in the esophagus are of several types. We can see a lymphocytic pattern, which can be seen with a lot of those squiggly lymphocytes between the keratinocytes that can be due to a variety of causes. Reflux disease, yeast infection, dysmotility, Crohn's disease can sometimes present this with this problem, contact irritation, as well as combined variable immunodeficiency, graft versus host, radiation therapy, chemotherapy, other sort of specialized circumstances can give you this disorder. We can see, as we have in these current slides, a very eosinophilic predominant pattern. That can be related to gastroesophageal reflux or to eosinophilic esophagitis and occasionally to some other disorders. A more neutrophilic infiltrate inflammatory pattern tends to be superficial and is more likely to be associated with peptic ulceration due to reflux or infection secondary to viral or fungal diseases. And ischemic inflammation or ischemic ulceration can also present with this pattern. Then there's this mixed category, which can provide mixed lymphocytic and eosinophilic, which, as you can see, could include obviously GERD and eosinophilic esophagitis, as well as some of these others with superimposition or mixtures of various factors. So in our case, these biopsies from 2 different levels of the esophagus showed very dense and active eosinophilic infiltrates. Typically, the cutoff is about 15 to 17 eosinophils per high power field. But as you can see here, sometimes that can be a little bit difficult to count. Sometimes the eosinophils are degranulated. We may miss a few cells, or we see so many granules that we don't know which nuclei they came from. And so the findings can be somewhat variable. We like there to be several fragments sampled and to help us in our evaluation, because as you can see here, there's very, very few eosinophils. Here's a couple over here, but nothing close to that threshold, and yet this is the same disorder, eosinophilic esophagitis. And here we see more eosinophils. Again, you can see the variability from area to area. So sampling is an important limitation to making this diagnosis. If we don't have a sample from the mid esophagus, it's virtually impossible to distinguish eosinophilic esophagitis from severe reflux. Having both, we can be more confident that it is an active eosinophilic esophagitis pattern. This is a disorder that occurs both in children and adults, though the clinical setting and circumstances may vary somewhat. With children, it's most often related to food allergies, whereas in adults, there may be other factors like drugs and genetic predisposition and so forth. There are several gene variants which are more likely to be associated with this. Clinically, these patients tend to have difficulty swallowing. They may have a sense of food sticking. And we should see some of those characteristic endoscopic findings that we've noted. As I've mentioned, the threshold is 15 eosinophils per high power field, and it needs to be well above the gastroesophageal junction, just to make sure that this is not just reflux. Now, there is some relationship to eosinophilic enteritis elsewhere, and we'll show you some images that might go along with that. So here's another example, another example of eosinophilic enteritis. Here we see gastric antral mucosa, and you can see the very dense eosinophilic infiltrate here in the lamina propria. The stomach usually has few or no eosinophils, so to find this number of eosinophils within the lamina propria is truly pathologic. What makes it even more so is if we begin to see eosinophils within the epithelial compartment as well. So be alert for that finding and aware that it may come in association. This more widespread eosinophilia may, again, be more likely to suggest a systemic rather than a specific contact association. Here's another example of eosinophilic gastroenteritis, in this case also associated with eosinophilic esophagitis. And again, we see this very prominent eosinophilic infiltrate in the lamina propria, occasionally present and involving the epithelial compartment with just a few cells within the columnar epithelium, as you see here and here. So our final find-out diagnosis today is eosinophilic esophagitis. In this patient, secondary to a dietary supplement, and probably associated with eosinophilic gastroenteritis in other foci as well. Well, thanks for joining us for this case discussion. If you like this video, please comment and share it. As always, we invite you to subscribe so that you don't miss future releases of similar, hopefully high-quality videos. And we always welcome your feedback, suggestions for new topics to cover. please feel free to reach out to me directly. The address is noted here. So until next time, thanks so much for joining us.